Michelle Wong-Brown is a postdoctoral researcher with the Centre for Drug Repurposing and Medicines Research, University of Newcastle, located within the Hunter Medical Research Institute here in Australia. Michelle's research is contributing to a growing body of knowledge about how drug repurposing, using old drugs in new ways, can provide treatment options for chemo-resistant ovarian cancer to improve survival rates. Welcome to Pure Health Hub, Michelle.
Thanks for having me, Lindy.
It's a pleasure and thank you. So now today what I wanted to do, Michelle, was really just have a chat about why some ovarian cancer patients experience this treatment resistance, but then also how, the positive news, repurposing existing drugs are being used to treat chemo-resistant patients. So ovarian cancer is the 8th most commonly diagnosed cancer in Australian women and has the highest mortality rate of 4.8%. So it's notoriously difficult to diagnose. Why is this, Michelle? And what are the symptoms? And in particular, any first signs we should be aware of?
Sure. So why is it firstly so notoriously hard to detect? I think because the symptoms, when I lay it out to you, you'll see they're just so vague. So they just seem like things that women will experience because they're women. So it's vague symptoms like having your period at the time of that month and you're experiencing bloating and indigestion. They're just common. And most women don't realize until something significant happens when they have abdominal bloating that they present to the doctor. And so ovarian cancer is often diagnosed at a more advanced stage rather than early stage where it has a better prognosis. So in terms of ovarian cancer symptoms, I do think it's easy to remember when you have something to help you remember it, like a mnemonic. So I take great pleasure in fitting out the symptoms to Pure Health. So, so P for pelvic or abdominal pain. So U for urinary changes. So you might have a change in your urinary movement, as in frequency and urgency. So R was a bit tricky, but we'll put it as irregular periods. So having menstrual inconsistencies or postmenopausal bleeding, and E for excessive fatigue. So as you can see where I'm going, they're pretty vague symptoms. And H for heartburn and change in bowel habits or constipation. E for eating, as in difficulty eating or feeling full rather quickly. So can you see the spectrum of symptoms you can?
Yes.
For eating, you can have difficulty or feeling full quickly. A for abdominal bloating, as in accumulation of gas or indigestion. They're all related to heartburn as well and bloating, so the abdominal bloating. And then L for lower back pain. So you could have just like a lower back pain that you experience when the time of the month is coming anyway. Yeah. T for tiredness or fatigue. And then I struggle with the last H. So we'll just leave it as health, weight fluctuations. So those are the symptoms of ovarian cancer that if you know it's abnormal, it's not something you regularly experience, then maybe pay more attention to it. I suppose women would know their own body better.
Yeah. And that's a lot about what we're about, is reminding us to tick back what's going on in our head and trying to just listen to what's going on in our body more. So right. I think this is very much about just reminding women to just stop and listen for just a minute. That's great. Thank you for that. Thanks for that use of Pure Health. So then how is it to tell? Well, obviously these symptoms is, someone's going to go to a GP and they're going to sort of tick off these. But then what happens then if a GP says, well, okay, well, let's go and test you for this. How is that done? Is that
so if you present to your GP and there's suspicions of what it could be, you generally get referred to for an ultrasound. So transvaginal ultrasound where they can kind of have a look at what's going on in your pelvic region. And if they see like a shadow of some sort, it will help them make a decision. But then they'll also do a blood test and test something called CA-125. The CA-125 is a blood marker that helps diagnose ovarian cancer, but it does not get used in isolation because CA-125 can be increased in other conditions as well, such as endometriosis. So an ultrasound coupled with a CA-125, and it could do an MRI or a CT scan. And if they've got a strong suspicion that it is, you could be referred to for like a laparoscopy as well. Take a tiny biopsy of the area and have the diagnosis.
So that's how. So there's a number of steps to diagnose.
Combination of tests. Yes.
Yeah. Yeah. Okay. So an ultrasound would be the first step, really, and then onto
the blood.
And the blood
tests. Yeah.
So now, for those who are resistant, do you become resistant to treatment for ovarian cancer, or are you from the get-go? And is there a type of person that is resistant?
That's a bit of a tricky one. You can be resistant to treatment from the get-go. So ovarian cancer is typically treated with drug called platinum chemotherapy. So when the patient is resistant from the get-go, they're termed platinum refractory, which means they just don't respond to the chemotherapy at all. But often patients have several cycles of chemotherapy. But when they have a progression of the disease within 6 months of their last treatment, that's when they're termed resistant to treatment. So usually people respond more than 6 months, and then they might have a little bit of a relapse, and then they get the next cycle. But when the period of having no progression gets shorter and shorter, then you're termed as being platinum resistant.
Right.
Usually, like there have been studies that retrospectively look at what separates a platinum response to a platinum resistance. And it's been found, several studies have found that if you carry mutations in your BRCA genes, your BRCA genes, you typically respond better to platinum chemotherapy. But of course, everyone gets treatment regardless. So you do not get stratified based on your mutation status. Yeah. Everyone gets given the same treatment.
Yeah. So that BRCA gene has got to do with not just breast cancer, but ovarian cancer. Any others that you're familiar with?
Yeah, so we all have the BRCA gene in its normal state. It works fine. It works to stop cancer. It's a tumor suppressor gene. But if you get mutations in these genes, it's a risk factor. You have a higher tendency to develop breast, ovarian, BRCA2 is associated with prostate. So bear in mind, it doesn't just come down the maternal line. So you could inherit a BRCA mutation from the paternal side as well. Right. That may not manifest as a female cancer. And then, so BRCA mutations are the highest risk factors for ovarian cancer.
Yeah. Yeah. So I guess then with this question, what I was going to talk about, can resistance be reversed, or are other drugs used in place in this case? What would be the next step if the chemo was not working?
Yeah. So firstly, can resistance be reversed? There are several studies that looked into it. Some have progressed to clinical trials. So it's called platinum resensitization. So having strategies that make the tumor start responding to platinum chemotherapy again. So yes, there are several clinical trials out there that are attempting to resensitize the tumor. So in essence, I suppose reverse resistance, or actually make the tumor respond again. Yeah. And these trials actually make use of drugs that are approved for other uses. So in a way, an example of drug repurposing. So a trial by a big group in America, they used a DNA methylating inhibitor combined with platinum chemotherapy. So
Right.
DNA methylation inhibitors, they're generally used in blood-based cancers. They've been approved for treatment of blood-based cancers.
Mm-hmm.
But additionally, they also prevent, or not prevent, reduce methylation of DNA.
Yeah.
So the genes that help you respond to chemotherapy actually get reactivated, re-expressed. So then you acquire response to chemotherapy again.
So that is that repurposing of existing drugs that we were talking about. So
Yes.
how successful has that been so far?
I believe it's in phase 2 clinical trials at the moment. I'm short of reading the outcome of the clinical trials, I cannot really comment. But yeah, the fact that preclinical studies were successful, so it's gone to phase 2 clinical trials. So watch this space.
Excuse me. So are there any other medications that can be repurposed? Is that the first of its kind that's going under the clinical trial too?
Yeah, I think it is, but people probably don't see it as drug repurposing, or just probably didn't tweak. But within our research group, we have found that an old drug used to treat HIV actually slows ovarian cancer growth in the lab, in cell lines. So it's a model of cancer that we use. They're called cell lines. We showed a response in them, but then in a separate model where we get the tumor from a patient and grow them in culture within the lab, we saw a similar response of this drug having an effect on slowing the growth. So combined, we have written a proposal for a clinical trial, and you never know, it needs to be endorsed. We need to convince clinicians, patients, and pharmaceutical groups to fund them. But yeah, that's one example that's come out of our lab.
Wow. You know, you guys, our medical researchers and scientists really are the unsung heroes of modern medicine. I mean, really, you're the ones who are affording life longevity for many. So for that, I thank you on behalf of everyone. But I think the other thing is that you researchers are a unique bunch, right? So what made you get into medical research?
In general, I just wanted to make a difference. It's so cliche. I wanted to make a difference.
Yeah.
I started off with breast cancer research, and I looked a lot at the BRCA, the BRCA genes I was talking about, looking at why people with breast cancer develop breast cancer. So the development of breast cancer. And then with that knowledge, combined with the group I'm in now, we were wanting to look at why patients develop treatment resistance, especially in ovarian cancer, where the survival rate is quite low. But then something that a patient advocate say, it's an awful term, patient advocate, but they're people who have survived cancer, come out the other end, and now advising cancer researchers like us. Wow. So something that the person said, it's fine, I know I've got cancer, I've developed cancer. How's your research going to help me? How is it going to make me live longer, respond better to treatments? So my research had gone from the why someone gets cancer to why someone develops treatment resistance to actually how can we help them overcome this when they've actually had a relapse, had a recurrence, and have been told they're resistant to all treatment now. Yeah. So it kind of progressed from wanting to know the why and changing course to actually trying to help patients.
Yeah, absolutely. And, you know, it's it's extraordinary, all of you. You know, as I speak to many of you in this fabulous role here at Pure Health Hub, but you never cease to amaze me of your commitment to that purpose. And it really is. I mean, you wouldn't do it unless it was a passion project, because I don't know how you do it, but
well, we always say they don't pay us very well, so you wouldn't do it if you don't like the job.
I mean, it's extraordinary, but obviously you're a special bunch of people. And I think for you, you know, you're talking about the resistance. And as you say, someone who is now basically has been told that they're completely resistant to all of it. Is there another step, or is that what you're working on now?
So we're not trying to cure cancer. I guess the step is to make everyone aware that the research that we do, it aims to make people live with cancer as if it's a chronic disease.
Yeah.
So you won't die from cancer, you just live with it.
Yeah.
And it might require taking a particular drug for the rest of your life.
Yeah.
Like diabetes or kidney disease. So we just live with it and won't die from it. So I suppose we need to change our focus to, you know, we need to find a cure for cancer. How about we just slow the growth enough that a person just lives with it?
Yeah, because there's so many variations. And I think, you know, that really is a message of hope when you talk about living with it. Sure, it wouldn't be pleasant, but you certainly get the longevity that you would like to be able to see your grandkids or whatever. So I think that's a really admirable and probably a completely realistic position, right?
Yeah, I hope so, because we don't want to give you a whole suite of toxic drugs that, yes, even if you prolong your life, you're not happy, you're constantly sick. So sorry, in addition to that, you want to live a long life with good quality of life.
Absolutely. Absolutely. And on that note, that's a great place to finish. Michelle, thank you so much, not just for today, but for everything that you do. It's been a pleasure, an absolute pleasure to chat to you.
Thank you so much for having me, Lindy, and the opportunity.